Welcome to the part 2 of Ophthalmology Rheumat Connect in Chronicles with Expert series. If you joined us for part 1, you will know that Dr. Kavitha shared some wonderful insights in the diagnosis and management of Sjogren's syndrome. In this part, we will build on that discussion as we explore all there is to know about PUK, delve deeper into the practical use of immunosuppressive therapy, and discuss some challenging overlap syndromes. So, without any further delay, let's get back to our conversation with Dr. Kavitha.
So let's move on to the scenario 3. Here there are two cases. A 60-year-old female patient presenting with peripheral ulcerative keratitis whose initial blood investigation came to be within normal limits. She stopped her immunosuppressive therapy and then she presented with the second episode of an active ulceration with significant thinning, and we had to start her again on an immunosuppressive therapy along with the steroids. On the other side is a 65-year-old female who is a known case of a rheumatoid arthritis, but for some reason again she stopped her immunosuppressive therapy and presented to us with a corneal perforation. Now we have two scenarios. One wherein you have a known underlying etiology which can be an RA, SLE, Wegener's, and on the other hand the initial systemic workup which comes as negative, and oftentimes we label it as a Woodin's ulcer. Do you see any kind of evolution into the seropositiveness of these cases whose initial workup is seronegative?
Two major systemic disease which can cause PUK is one is rheumatoid arthritis, other is granulomatosis with polyangiitis. Most of these antibodies are preclinical antibodies. They tend to happen 3 to 5 years even before the disease develops. If a patient develops rheumatoid arthritis and I do a rheumatoid factor and an anti-CCP today, if it's like negative, I assume it is negative only. I wouldn't repeat it every 6 months just to see whether it is increasing or decreasing. Usually no. But in such scenarios, when every workup was negative in the initial thing, but she tends to progress on with the PUK, in that case I would suggest repeating it at a good center. That's most important. Sometimes ANCA is done on a routine setup, only an IF is done. We do not have an ELISA workup. Then definitely I would do a ELISA workup of MPO and PR3, both of which are antibodies for your ANCA associated vasculitis, under which GPA, granulomatosis with polyangiitis, which is also called as Wegener's, plays a role. If done at a good setup, you can consider it as negative, but repeat at a standard lab with a good technique. Rheumatoid factor with an nephrometry, anti-CCP, ANCA, MPO and PR3 in ELISA. Along with IAF, the antibodies do not go and become negative, becomes positive, positive becomes negative. No, they are preclinical. The technique of doing an antibody is very, very, very important.
Dr. Kavitha, if you can just very comprehensively tell us regarding the efficacy, safety profile, the dosage, side effect of immunosuppressive therapies that we as an ophthalmologist should be aware of.
Methotrexate has this tendency to cause leukopenia. Dosage should be a weekly dosage. Patients tends to take it daily, come to us with a bone marrow suppression. So it's important, talk to the patient, advise them saying that it is a weekly dosage. And every time we give a methotrexate, we need folic acid the next day, which will reduce the mucositis and the bone marrow suppression side effects of methotrexate. Start at 10 milligrams, escalated to 15, sometimes even 20. Do a preliminary CBC, LFT, along with CBC, LFT every month for the first 3 months and then once in 3 months. Most common side effect being transaminitis or the bone marrow suppression. Next comes azathioprine. Thiopurine methyltransferase deficiency do exist. So it's like very important to start very low and then titrate the dosage every week till we go to the maximum of 1 to 3 milligrams per kg body weight. And mycophenolate mofetil, one of the safest drugs to use. Start at maybe 1 gram. See whether they are tolerating. Increase it to 2 grams or 2.5 grams as needed. Look for the GI symptoms and also the complete blood count, serum creatinine and SGOT, SGPT every month for the first 3 months and then once in 3 months or once in 4 months. Efficacy wise, I would say for Murens, peripheral ulcerative keratitis, OCP, mycophenolate mofetil does wonderful for treatment protocols. But if the patient is a very strong positive rheumatoid factor and anti-CCP and the ANCA is very strongly positive, that is antibody driven disease which is progressing in spite of other immunosuppression, rituximab is a wonderful choice of drug. Whenever there is an ophthalmological emergency, particularly PUK in a patient with RA or ANCA-associated vasculitis, we can directly go ahead with rituximab. It's important to talk about pharmacoeconomics to the patient also, whether they are able to afford it for a longer time or select a drug which the patient will be able to afford. Economy also drives our compliance. The patient assumes mycophenolate mofetil is slightly on a costlier side. Instead of taking 2 in the morning and 2 in the the night, they tend to skip and take one in the morning and one into the night. We don't have routine blood tests which can see whether the patient is compliant to the drug or not. So it's important how fast you want a drug to act, how efficacious it should be, and whether the patient could be compliant to drugs.
In patients where you have an underlying systemic etiology, does choice of first line immunosuppression differ in different diseases, or it is the same for everyone?
Different diseases, different choice of immunosuppression. Particularly PUK associated with ANCA-associated vasculitis, the patient does pretty well with rituximab as the first choice of drug. The general guidelines for ANCA-associated vasculitis itself has moved out from methotrexate and on to rituximab for us. And then with rheumatoid arthritis, for the joints part of it, only methotrexate initially is enough. If there is an eye involvement, maybe an addition of mycophenolate mofetil or directly going with rituximab definitely helps.
Also, ma'am, is there a difference in efficacy of oral and subcutaneous methotrexate? Like if the patient is not under control with an oral, can we shift to subcutaneous?
What I do in my practice is methotrexate works well, but I want the dosage to be slightly above 15 mg. I want to go into 20 or 25. I prefer a subcutaneous dosage because the bioavailability of oral methotrexate reduces once it goes beyond 15 mg as oral therapy. We have pre-filled syringes currently for 15 milligrams and 20 milligrams. And one more indication, the disease is under control, but the patient is not able to tolerate. The GA symptoms becomes very high. That is when I shift them to subcutaneous methotrexate.
Also, we usually start the patient on oral steroids and immunosuppression hand in hand. Any recommendations for oral steroids? We have various options available like prednisolone, methylprednisolone, betamethasone. And what do you suggest should be the tapering of oral steroids? And does it differ with different immunosuppression that we are starting, or is it the same?
For a PUK part of it, once you give IV methylprednisolone, I would prefer adding up a steroid sparing agent. Depending on your disease activity, could either pay a methotrexate or a mycophenolate mofetil or a rituximab. If it's severe and organ threatening, go ahead with rituximab straight away along with methylprednisolone. The fourth day of methylprednisolone, you can give rituximab. Or if it is like mild to moderate, you again go with methotrexate or mycophenolate mofetil. Escalate mycophenolate mofetil as soon as you can. With 2 to 3 weeks, you go to the maximum dosage of 2 grams. Starting the steroid sparing immunosuppression as early as possible is advantageous in controlling the disease activity. I would prefer a prednisolone, which is like easily available, Vizolone or Omnacortal, because most of our treatment protocols tell you 1 milligram or 0.5 milligram per kg body weight prednisolone. It has a very good anti-inflammatory property. So you don't take stress in recalculating dosage and all. You stick on to IV methylprednisolone, either 500 mg or 1 gram 3 days as pulse therapy. Then go ahead with oral prednisolone either at 0.5 milligram per kg body weight or 0.75 milligram per kg body weight. Usually we start reducing it once in 15 days in rheumatology, 5 milligrams or sometimes even 10 milligrams if it is adequately controlled. This is where your steroid sparing immunosuppression helps. You start methotrexate at 15 milligrams straight away and the patient's disease activity is controlled. That allows you the option of reducing steroids slightly on a faster side. Again, mycophenolate mofetil at 2 grams or 3 grams upfront and disease activity is well under control, you can start reducing steroids usually very fast. And similar to with the rituximab. So if it's very severe, I would prefer rituximab upfront, or if it's like moderate, mycophenolate mofetil, and mild, it is like methotrexate.
So once we have started the patient on immunosuppression, we have tapered off the steroid, there is a period of quiescence of the disease. Sometimes we see reactivation of PUK. In such a scenario, how should we go ahead? Is drug that is given insufficient? Is the duration of the treatment insufficient? Do we need to switch over to some other kind of therapy? Just enlighten us on that.
So when we talk about a reactivation of disease after a period of quiescence, the first thing which comes into my mind is the drug incompliance part of it. Many of our patients are drug incompliant. They do not maintain the drug level at all. Assuming the patient has been very stringent with their drugs intake and still the disease reactivates, I have two options. One is escalate same drug to a slightly higher level, which is actually performed quite well because the patient had attained the quiescence, or change of drug from one immunosuppression to other immunosuppression under cover of steroids. Whenever there is a flare of an ophthalmological issue in a systemic disease, steroids are the first choice, be it uveitis, be it scleritis, be it episcleritis, because we want immediate action. Do not change from one immunosuppression to other immunosuppression without the steroid cover. That tend to badly affect the eyes, because the new drug will definitely take at least 4 to 6 weeks for it to act.
And what is the role of cyclophosphamide and biologic in such a scenario?
See, rituximab is a biologic anti-CD20, which is very good for granulomatous polyangiitis and rheumatoid arthritis. arthritis. Coming to a scenario where the patient will not be able to afford for a rituximab therapy, choice for me will be cyclophosphamide. It acts very fast. 2 weeks is time duration it starts acting, but the side effect profile is slightly on a higher side. Infection rate is slightly high. Life-threatening neutropenia can happen. I go with pulse cyclophosphamide injectable therapy, 15 mg to 20 milligrams per kg body weight to a maximum of 800 to 1000 milligrams once a month, at least for 6 months, for the disease to become quiescent, and then they shift up to any other oral immunosuppression. Again, always give with mesna, which is very good in preventing a hemorrhagic cystitis. For any ophthalmological emergency, cyclophosphamide is one of the best drugs which we can use, but it is being used less currently because of the advent of rituximab with slightly lower side effects, not because cyclophosphamide doesn't work.
And Dr. Kavitha, is monitoring cure any different from what we have already discussed, or is it the same?
See, rituximab doesn't have much of a monitoring issue. Before giving rituximab, serology hepatitis B and C is very important because it has a tendency to reactivate a silent hepatitis B and C. And again, the complete blood count has to be taken 1 month later. Apart from that, rituximab is very safe. When it comes to cyclophosphamide, we always do a complete blood count and a SGOT, SGPT before every infusions, because many times the total count will be very low and it takes slightly higher time to come back to normal for certain people. For most people, it come back to normal in 3 to 4 weeks, and it is also good when the patient is on high dose immunosuppression like steroids, cyclophosphamide or rituximab for antifungal and an anti-pneumocystis prophylaxis like cotrimoxazole.
Thank you, Dr. Kavitha. That was a very comprehensive and practical overview. You have very nicely clarified on the efficacy, duration of action, safety profile of all the common immunosuppression, and it's very insightful for us as an ophthalmologist who do not deal with such agents on a regular basis. And as it is rightly highlighted that PUK should be considered as a systemic disease, not just an ocular disease, and should be managed aggressively with appropriate collaboration with the rheumatologist.
So we'll move on to the last case of this session, overlap syndrome. Here we have a 60-year male who is a known case of rheumatoid arthritis on methotrexate. A punctal cautery was done for a severe dry eye. Now his rheumatoid arthritis is under control. On examination, he has a tarsal inflammation with the presence of subconjunctival scarring as well as corneal short. This cicatricial changes made us to suspect ocular cicatricial pemphigoid. The case of overlap syndrome where there is an ocular cicatricial pemphigoid along with secondary shock with rheumatoid arthritis. So in these cases, do they require two different types of immunomodulators, and which disease becomes a deciding factor?
When we have a isolated rheumatoid arthritis, we go only with methotrexate, right? But as OCP is there, OCP, the first choice drug itself is mycophenolate mofetil, and OCP will not get controlled with methotrexate. First option, if arthritis is under control, keep methotrexate on and add up mycophenolate mofetil, because most of the studies puts mycophenolate mofetil as one step higher to any other immunosuppression when it comes to OCP, because per se it's a anti-fibrotic. So cicatrization is there, fibrosis has to be reduced, so mycophenolate mofetil plays a very good role. And if possible, if the arthritis is well under control, from the 15 mg I would try reducing it to either 12.5 or 10 milligrams and maintain it at the lowest possible dosage. Again, patient is on dual immunosuppression, I would repeat the complete blood count and SGOT, SGPT very frequently, maybe once in 15 days when I start them, and slightly once a month always. Usually methotrexate with remission, I do it once in 3 months. Why I am not changing methotrexate completely to mycophenolate mofetil is mycophenolate mofetil does not play a good role on the joints. It doesn't have a joint control at all. So adequate arthritis control with methotrexate at the minimum dosage needed, and OCP is also under control with mycophenolate mofetil. This is an option. If OCP is again progressing, second option will be a rituximab therapy, which will take care of both the arthritis as well as the OCP.
So when there are two diseases together, so how to differentiate which one is under control and which one is not?
You will tell me whether the ophthalmological part is under control or not. I talk with Dr. Varsha, I talk with you just to make sure that the ophthalmological disease is under control or not. Patient don't have any major tender joint or swollen joints. They are able to perform their day-to-day activities well, and their ESR CRP is also under control. I assume my arthritis is under control. Sometimes if this is under control, that is flaring up, I might escalate my immunosuppression.
With regards to side effects of combining immunomodulator, which specific blood markers will monitor?
There are certain drugs which I combine, certain drugs I don't combine. I combine methotrexate with mycophenolate mofetil, but I do not combine methotrexate with azathioprine because both of them tend to directly affect your bone marrow. Life-threatening neutropenia can happen. A definite no for me. But methotrexate with mycophenolate combination is absolutely okay with me. But the most important thing which you have to monitor is the complete blood count because the neutropenia does happen. The WBC goes less than 3000 many times in such patients. Rituximab, I can combine a mycophenolate mofetil or even a methotrexate. Both of them are completely safe. But when I choose cyclophosphamide, I would not dare put any other immunosuppression. Patient can have febrile neutropenia with cyclophosphamide. The only other immunosuppression, if you ask me, steroids alone is allowed. One drug where I am extremely careful and no methotrexate, no mycophenolate mofetil along with cyclophosphamide.
How does pregnancy and breastfeeding shift our choice of immunosuppressants?
There are absolute contraindications for certain drugs. Like methotrexate is a category X drug. Mycophenolate mofetil cannot be used. Cyclophosphamide definitely no. Rituximab at least 6 months prior to getting pregnancy you have to stop it. So these 4 drugs are off first. Pregnancy and lactation, you have an eye issue. Steroids are very safe. And the second thing which is very safe is azathioprine. Mostly our go-to choice drug. Again, hydroxychloroquine is very safe. And the third drug which is very safe is the tacrolimus. I haven't talked much about tacrolimus, but it is as good a drug for many of the ophthalmological conditions. Just that we have to have the blood levels of tacrolimus checked whenever we escalate the dosage, and not every patient behaves equally well with tacrolimus. So 2 things which you have to monitor is your renal function test along with potassium levels and glucose levels. Apart from the usual complete blood count and OTPT, patient tends to have hyperglycemia, hyperkalemia also. 3 drugs which can be very safely used apart from your steroids is azathioprine, hydroxychloroquine as well as your tacrolimus. Anti-TNFs are absolutely safe. Particularly adalimumab is very safe during pregnancy. One thing which we have to tell patients on anti-TNF injections and adalimumab throughout pregnancy for the eye part of it, when there is a child born, the child should not take a live vaccine like oral polio vaccine and a BCG vaccine. But if we have stopped it at second trimester, that's okay. And JAK has been upcoming, particularly in cases of uveitis. We haven't had much of studies for the PUK part of it till now. But JAK inhibitors are not safe during pregnancy and lactation.
To summarize, we prefer a combination therapy of overlap syndrome and be extremely cautious in combining 2 medications. Rheumatologists and ophthalmologists work hand in hand to monitor the disease activity and to identify which one is under control or not.
Dr. Kavitha, this has truly been a wonderful and very insightful discussion. Going through this practical real world case scenarios with you have given us an invaluable clarity on how we should approach and monitor these patients. I'm sure our viewers will also agree that these insights have been extremely helpful in bridging the gap between ophthalmology and rheumatology. As I wrap up, I would like to extend my heartfelt thanks to you for taking time out and sharing your expertise with us. May I request you to share some key take-home points?
Key take-home points is like always talk to your ophthalmologist first to know how the disease is actually, because many times we don't have a cross consultations. So I mean, I work very closely with you, so I am very comfortable where we talk about our patients. There are certain clinical clues which an ophthalmologist will throw to us where we can change the immunosuppression and make sure the patient gets benefited out of it. And many times if systemic disease is under control, I would say ensuring proper ophthalmological control goes a long way in protecting the eyes, and always slightly being aware of newer techniques and newer drugs in ophthalmology and rheumatology in select a perfect immunosuppression for the patient.
Thank you so much, Dr. Kavitha.
Thanks, Dr. Mugundan. Thanks, Smrita ma'am, and thanks for
Thank you so much.
At Ocular Surface Gurukul, learning is a two-way journey. Have a question, a suggestion, or a topic you would like us to discuss? Share it in the comments or send us an email. We would love to hear from you. Stay connected and see you in our next insightful episode.